Good afternoon.
Good afternoon, everyone.
Good afternoon. Good afternoon to you.
Yes, you're welcome to today's Echo session being hosted by EMS Echo and Seed Global Health with Ministry of Health. Today's topic, we are going to see poisoning and snake envenomation. So I'll request my colleagues to introduce themselves. I will start introducing myself. My name is Nabuuma, an emergency nurse working with Kabale Regional Referral Hospital. I'll ask my other colleagues to introduce themselves as per the poster. Dr. Amanda.
Good afternoon. I'm Dr. Amanda Williams. I'm an emergency physician, a seed educator working at Mbarara Regional Hospital.
Thank you, and she's our expert today. Dr. Joseph, I think you're online.
Yes, good afternoon, everyone. My name is Emuron Joseph. I'm an emergency physician. I work with Katakwi General Hospital. I'm happy to be part of the session.
Thank you. Dr. Fiddy.
Good afternoon, everyone. I'm Dr. Fiddy Obalim, Intern Dr. Lacor Hospital, currently in surgery department. Thank you.
Dr. Emma.
Yes, good afternoon to you all. I'm Dr. Makai Emmanuel, a medical officer at Lacor Hospital, and we shall be doing a case presentation. Thank you.
You're welcome. Now, on our program, let's go through the program. We had the introduction of the session and the key personnel. So we are going to have our pre-test and session expectations. We shall have our presentations. We shall start with the snake bite patient case presentation and reactions. It will be done by Dr. Obalim Fiddy, and we shall go to snake envenomation by Dr. Emuron Joseph. He will take us through the assessment, emergency management, and complications. Then we shall have our questions and answers. We shall have the organophosphate patient case presentation and reactions by Dr. Makai. We shall have organophosphate poisoning, assessment, emergency management, and complications by Dr. Amanda Williams. Then we shall have the session discussion. We shall have our closing remarks and post-test questions and screenshots. Thank you. Let's have our pre-test running as we receive our expectations from today's session. Our pre-test is running. We can be doing it as we receive the expectations. Our participants, you can be sending in your expectations as we are doing the pre-test. It will take just a few minutes.
I don't see any pre-test on my screen.
Clicking.
The pretest has disappeared before we completed.
It is
Please
on.
watch the pretest
The computer,
first.
you can.
We are still doing the pretest, it is off.
The pretest has disappeared before we completed.
Test has been disappeared.
Okay, participants, the pretest is on. You can answer. So in our expectations, you can be putting up hands and be telling us what you expect from today's session as we continue.
Yeah.
Someone is saying the audio is low. Okay, in our expectations, one is saying, I expect to learn the names of all snakes. Another expectation, someone is saying differences between venomous and non-venomous snake bite patient presentation. Another expectation, someone wants to know if tying is still allowed to prevent flow of venom to other parts of the body from a site of bite. Another one is saying if there is availability of pyridoxine in NMS and other pharmacies. Another expectation is first aid and definitive management of snake bite and venomous poisoning. I think we are done with the pre-test. So we can move on our next program. Let's get the presentation of snakebite patient case presentation and reaction from Dr. Fiddy. Dr. Fiddy, you're welcome.
Thank you, team. Once again, I want to thank everyone for making it to this CPD. As I've introduced myself before, I'm Dr. Obalim Fiddy, Intern Dr. Lacor Hospital, Surgery Department. I'm going to be taking you through a case presentation on snake envenomation. Okay. I'm presenting a case of OR, a 33-year-old male who came in as a referral from Iwa Medical Center for further management. The referring point is about 50 kilometers away from Lacor Hospital. Came in following a snake bite 12 hours prior to admission. Was reportedly bitten on his right lower limb. His presenting complaints at that time were 4 episodes of vomiting, difficulty in breathing, conversion, reduced consciousness, and swelling of the right lower limb. Pre-referral intervention was IV fluids and IM diclofenac given before referring the patient. On arrival, this patient was rushed to ICU because for cardiopulmonary support. Being a trauma case, we followed our primary survey where we started with the airway. Notably, the patient was unconscious and unable to talk, had frothy secretions in the mouth, and this patient was already intubated in ICU at the time of clerkship. Our intervention at that time was admit the patient to ICU and suction secretion. Breathing, and the patient was under mechanical ventilation with a respiratory rate of 28 cycles per minute, normal chest shape, vesicular breath sounds with equal air entry, bilateral. Chest was clear, and SpO2 at that time was 97% on mechanical ventilation. Our intervention was to maintain oxygen therapy via mechanical ventilation. Saturation, the patient was not pale, no external bleeding, had cool extremities, pulse was full volume and regular at the rate of 81 beats per minute. Blood pressure was 99/44 millimeter of mercury. Intervention at that time was to start IV fluid therapy, 2 liters in 24 hours, inserted urinary catheter, and monitoring of urine output was started. Disability, we noted reduced consciousness. GCS was 60 with eye opening of 2, motor 4, and verbal was T. Pupils was 3 millimeter bilaterally equally, reactive to light. We noted fasciculation at lower limbs and face. There was normal muscle tone and reflexes. Random blood sugar was 14.2 millimole per liter. Our intervention at that time was to do a CBC, serum electrolytes, renal function test, and liver function test. At that point, we administered antivenom, specifically a polyvalent one. IM tetanus toxoid vaccine was given. Care for unconscious patients started. On exposure, head to toe examination done. Notably, we noted swelling of the right lower leg. However, we could not identify any bite mark. Abdomen were of normal findings. At that point, we were able to receive our investigation result, where we had CBC result ready with a leukocytosis of 13.6. HB at that time was 13.7, platelet of 152. Creatinine was 1.5, which is elevated, urea 42. Sodium was 150.1, elevated, potassium of 4, chloride 120.3, also elevated. Our ample history, there was no allergy. The patient was not on any medication at the time of the incident. Past medical history, this patient has no known chronic illness. Patient received IV fluids and analgesics at referral sites. Patient spent 10 hours at the referral site before arrival at Lacor. Last meal could not be ascertained since the patient was unconscious and was brought in by bystanders. Events at that time, the patient was in the garden at the point of bite, and the snake was not seen, and there was no any witness to tell us which snake, how the snake looked like. We had an impression of neurotoxic snake bite and having spider bite, scorpion envenomation, while ruling out cardiovascular accident as our differentials. Our problem list: 1, neurotoxic envenomation, labored breathing, reduced consciousness, ruling out organ injury. We had our follow-up plans for this patient. Day 1 after admission, notably the patient had profuse sweating, conversion, fasciculation, specifically from the lower limbs and facial muscles. Blood pressure at that time was 128/67 millimeter of mercury. Pulse rate was 80 beats per minute. We noticed secretion in the mouth. Glaucoma scale of 10T. Pupils were constricted and unreactive to light bilaterally. Patient had received antivenom already. At that point, we gave the patient a loading dose of IV phenytoin. IV atropine was also given, hydrocortisone, and we continued with our fluid therapy. NGT for feeding was inserted and recommended a second dose of antivenom. However, for this particular patient, we were not able to get the second dose. We also recommended 2-hourly turning in bed to prevent pressure showers. Day 2, after admission, there was marked oral secretion and generalized fasciculation at this time. The patient had depressed cardiac activity on ECG. Our intervention at that point was to give IV calcium gluconate, IV adrenaline, and atropine, and we started the patient on IV ceftriaxone. We maintained the patient under sedation with morphine and midazolam. On day 3, the patient reported fevers, generalized fasciculation, and temperature at that time was 40.9 degrees Celsius. Blood pressure at this point was 70/33 millimeter of mercury, which is low. Pulse rate was 109 beats per minute, which is elevated. SpO2 was 98% on mechanical ventilation. Glaucoma scale of this patient on that day was 90/15, and the patient was under sedation. Urine output was low. We noted 80 mils over the past 4 hours after the patient receiving 2.5 liters of normal saline. Renal function tests, at this point, creatinine was 58.2, urea was 225.9, which is elevated. Potassium was 2.86, and ALT was 7 times elevated, and AST 20 times elevated. Our impression at that time was acute kidney injury and acute liver injury based on our liver function test and renal function tests. At that point, our interventions were, we initiated cooling the body with ice pack, IV paracetamol, IV PISA, and IV pancuronium, IV dexamethasone were given. However, even with the giving of paracetamol IV, still there was no remarkable change in the temperature. It was still fluctuating around 40.9 to 40.7. IV potassium chloride were given, IV fluids, normal saline specifically, and adrenaline infusion was started while monitoring urine output. Second dose of antivenom still was recommended, but we were unable to get. On day 4, patient, there was some good improvement, and at this point, the patient was extubated. Still now, fasciculation was only located at the calf muscles. The patient was febrile. Glaucoma scale had improved to 13/15. Blood pressure was 116/70 millimeter of mercury. Pulse rate was 70 beats per minute. Patient was saturating at 98%, this time on nasoprong. IV potassium chloride was given, and the NG tube was removed, and the patient was started on oral feeds. Day 5, there was great improvement. The patient was able to feed orally. GCS was now 15/15, no respiratory distress, only noted mild fasciculation on the lower limbs bilaterally. Noted the patient received only 1 dose of antivenom, which was given on day 1, and a time to get antivenom at that point was not possible for this particular patient. Our intervention at that point was to start the patient on physiotherapy and transfer out of ICU to general ward. And currently, we still have this patient in our general ward, but has greatly improved, and the patient currently has no major concern, though we are still monitoring for sequelae of snake bite. Thank you very much. That was our case. Back to moderator.
Thank you so much, Dr. Fiddy. To our participants, I think we can be receiving some of the questions from that presentation. Before we continue, you can raise up your hand or you can send them through the chat. So in some of the questions, I've received one. Someone is asking, Dr. Fiddy, I think you're on. that paracetamol with acute liver injury, was there any rationale? Weren't there any other option for antipyretics? Then someone else is asking how many doses of antivenom were the patient supposed to get and why? I think this will be answered together because another one is asking if how many antivenom doses are recommended in the management. So Dr. Fiddy, you can give us, you can respond to those questions as we proceed.
Okay, once again, thank you for those who sent in their question. I'm going to start with the first question. Someone inquiring about the use of IV paracetamol in this particular patient. Yeah, alternatively, we could have used diclo, but still you realize this patient also had features of acute kidney injury. And having that temperature at 40.9, 40.8, we still put the patient at risk of more organ failures. So we opted to give the paracetamol than avoiding it. Then the question on how many doses of antivenom a patient is supposed to receive, this one, it depends on the presentation of the patient. So long as you assess your patient and you still see that the patient is in danger and presenting with severe symptoms, like for the case of this patient where we were having temperature elevated, the patient was in shock, there was recurrence of conversion and persistent fasciculation. This patient was still had constant indication for receiving antivenom, even 4 hourly, for the first 2 days. But because of the cost implication, the unavailability of the antivenom at that time, we were able only to give 1 dose. Thank you.
Thank you, Dr. Fiddy. I think we can proceed with Dr. Emuron Joseph to handle the snake envenomation, assessment, emergency management, and complications. Dale, you can ask your question.
Can allow me to share the screen or you share the presentation?
Okay, thank you.
Should I proceed?
Yes, you can proceed.
Okay, thank you. This is Dale, MRC. So to the doctor that has presented, they noted their provisional diagnosis as a neurotoxic venomation, and yet on the CNS, a CNS assessment, they noted that there is no more muscle tone and strength. So probably I would say, what was the justification for such a diagnosis or such a specification of venom? And yet they were not able to see or define the type of snake in that regard.
Dr. Fiddy is going to answer. Thank you so much.
Okay, thank you once again. Our impression of neurotoxic snake bite was based on basically looking at the GCS, the difficulty in breathing, and then persistent fasciculations, which was generally estimated as have the impression of neurotoxic snake bite.
Thank you so much, Dr. Fiddy. Let's proceed with Dr. Joseph to handle the snake envenomation assessment, emergency management, and complications.
Yes. Good afternoon once again. Can everyone see my screen?
Yes.
All right, thank you.
Yes, we can see the screen.
Okay. All right, thank you very much. So we are going to have a discussion on small envenomation. The key highlights in the program is the assessment, management, and complications. But when I prepared this presentation, I thought the audience is broad. It has clinicians, and then there might also be people who are not fully like clinicians. So we will begin with a bit of overview about snake envenomation. So globally, there are about 5.4 million snake bites annually. And out of those 5.4, about 1.8 to 2.7 million cases of envenomation. And you can see the death is about 81,000 to 137,000. And that's just in terms of mortality, but also in terms of disability. We have snake bites causing more amputations and then other permanent disabilities. And majorly, the people affected are children, farm workers, women, and usually this is in rural settings and in healthcare systems which are weak, which do not have antivenoms available already, high quality antivenoms. So if you look at the global map, it's actually showing us the number of envenomation per continent. And when you see in Asia mainly, there might be a quite high number of envenominations, and more than 100,000 people die annually. And then followed by Sub-Saharan Africa, and then South Asia. So in other countries, you can see Europe, you can see North America, the people who actually died because of the snake envenominations are very few. This is because their healthcare systems actually have high quality antivenoms available for patients. When you do have high quality antivenoms and you give them time, this problem can actually be reversible as compared to other health conditions. Okay, so also in terms of snakes, there are so many snake species. There are about 3,900 snake species that exist. But not all the snakes are poisonous. Actually, 80% of snake species are non-poisonous. And also when a snake bites you, not all the snakes actually inject a venom in you. Some snake bites are dry, meaning a snake will bite you, but it will not inject antivenom. There was an interesting study which was done in Uganda, Kenya, Zambia. This study basically looked at the patient profile. It looked at the knowledge of health workers when it comes to managing snake bites, and also looked at availability of snake antivenoms. Actually, this study found out that there was not so much variation in terms of the gender. And normally the people who were mainly bitten, they were within the age of 21 to 30 something years. And in terms of training, the health workers, around 12% of health workers have reported that they received the training about the management of snakes. And in terms of availability of antivenom, among the hospitals that were surveyed, only 20% reported that they had antivenom. This study was carried out in different hospitals, and they were involving government, private, not-for-profit. But when you look at the data, it basically means that in terms of the training for health workers, the knowledge on management of snake bites is low, but also availability of antivenom in our healthcare is really low. So when it comes to actually now the snake bites, it's very important to first understand the types of venomous snakes. We categorize them into three. When a snake bites you and injects a venom, the venom can be categorized into three. There are those venoms which are cytotoxic, and basically means those are venoms that will destroy the cells, damage the cells. And then we have hemotoxic venoms. Those are venoms which will affect the clotting or the coagulation. It will cause coagulation disorders. And then we have the neurotoxic snake bite. Basically, those venoms affect the nervous system. They destroy or cause death of the nerve cells. So when a patient presents, you may not be able to tell the type of snake, because sometimes snake bites can actually happen in the night. You may not be able to see the snake. And sometimes it happens to someone when other people are not there. So, but using the signs and symptoms from this, you might be able to tell this is the type of snake. So quickly run through these different types and the clinical presentation, when it is this type of snake. So we have a family which is called Elapidae, and basically the characteristic of this family, they have smooth scales, they have round pupils, and they have short fixed fangs. And examples of them include the cobras. Cobras are quite common in Uganda. And then we have the mamba. So when these snakes bite you, they will inject you a neurotoxic venom. And that venom, this is how it presents. Often you may not see a lot of the local symptoms, a lot of swelling. But normally it causes some sort of paralysis because it affects the nerves. So you'll have descending paralysis. Some cranial nerves will be affected, and then respiratory muscles. So these patients may present with things like tremor, salivation, dysphagia, which is slurred speech because the muscles of speech are weakened, diplopia, ptosis, fixed meiosis, seizures. So basically, they will come with neurologic symptoms. And sometimes also these snakes, they can just spit. And when they spit, for instance, if the antivenom lands on the eye or even the skin, it causes a lot of irritation. And then we have the cytotoxic snakes, and these are the family of Viperidae. And basically, their characteristics, they are long, hinged fangs, triangular in shape. And these ones, they are really big. You can see the puff adders here. Those are examples of these snakes. And when they bite you, cytotoxic, they cause a lot of local swelling in that area. You get blisters, you get necrosis of tissues, and then hemorrhage, ecchymosis, myalgia, myoglobinuria, which is black urine, and you can have features of renal failure due to myoglobinuria. And also you can have things like hypotension and arrhythmia. So basically, these ones, they cause a lot of local symptoms, and damage of cells releases some other chemicals into the system, and those chemicals may have systemic effects on the heart, systemic effects on the kidneys. And then we have hemotoxic venom snake bites. So with this one, it is this family Colubridae, and the characteristics, their fangs are rare, they're a bit behind, and their eyes are large, and it's like an egg shape in the head. And
I wish we had slides projected so that we can see these snakes projected. There are no
snakes
slides.
are there. Hey.
Yeah,
the slides well.
The slides are projected. Why are you not seeing them?
The slides are projected, please.
The slides are projected clearly.
Log off and log on again, you will see them.
Okay, so example of this snake is the boom slam, and it is indicated there. And basically the features of this snake are mainly related to bleeding. They will bite you at the side, and then someone will start bleeding from the side. But they also may have systemic effects such as headache, nausea, vomiting, and basically this type of antivenom, they require a specific. They may not have the other polyvalent antivenom. It requires a specific antivenom for it. So basically, when you understand those three, cytotoxic, hemotoxic, and then neurotoxic, then based on the presentation, you'll be able to tell the kind of snake which could have bitten the person. So in the management of snakes, usually you have the out of hospital environments. Maybe these things can happen in the community. And you also have the in-hospital. So the first aid, we'll start with the first aid. What first aid should be given to this person? So usually, if someone is with somebody who has been bitten by a snake, you have to ensure that your safety comes first. And some snakes can be aggressive. They will want to bite many times, especially the mamba. For it will bite you even more than one. And every bite, the snake is injecting a poison. So if you get many bites, you're likely to get a very big dose of the venom. So you have got to find that you're safe. If you can use a stick, maybe to chase a snake or try to kill, but you have got to mind your safety. If the snake is not there, you have to remove this person and put them in a location where you can handle them. And then you try to identify, identifying the snake. This is really tricky, but I know some communities, a snake can be killed, but in most cases, the snake disappears. You won't find it there. So in the first aid, what's really important is to keep this victim calm and still. And the reason for that is that when someone is calm and still, it reduces on the adrenaline. When you have a lot of adrenaline, you're going to have this venom distributing itself in the blood circulation quick and going to affect different systems. So keep the victim calm and still, and try to in keeping them still, you can actually immobilize the limb. Some pictures will come on how to immobilize, but when you immobilize, make sure that you're not restricting the blood flow. And be prepared for CPR. Basically, if it's a neurotoxic, you might actually have respiratory arrest, sudden respiratory arrest, and you might need to resuscitate this patient. And they, of course, prepare and transport this person quickly to a hospital, if possible, a hospital where you can access antivenom. I know there are so many practices out there in the community when it comes to first aid or management of antivenom. People will give you herbs, people will say you suck, people will say you tie tourniquet, you put a black stone. So all those things are not they are not recommended. They will actually do more harm than good. And then when your patient comes to the hospital, you receive the patient, you go to reassure this patient, and we know that some of the snake bites actually dry. So initial assessment usually follows the ABCD. And in your airway, you're going to no, is it airway patent or the airway is not patent? So if you have things like secretion, as in the case they just presented to us, so they found that person had a lot of secretions and they suctioned the secretions. And that patient was unconscious and they had to secure the airway. They intubated that patient. But also that patient had issues with the breathing. So you do the airway assessment. In the breathing, especially for the neurotoxic snake, you want to really understand what is the respiratory rate and then the quality of that respiration, the depth of breath. How does someone take in? What is the quality of the breath? And if you find that it's not good, let's say less than 10 breaths per minute, and the very shallow respiratory breath, and then SpO2 is also low. Supplement with oxygen, but ideally, these are patients you should prioritize early intubation and ventilation. And an example is the case we have just had. And then in the C, you're going to assess your saturation. You're going to check your peripheries. Are they warm, capillary, and then you do your blood pressure, the pulse rate, and also you can check for pallor. So in the event that you get this patient hypotensive, or there is evidence of abdominalitis, you have got to give this patient fluids, and you've got to be conscious in case you have issues in the airway. Maybe you listened and you found crackles. You've got to give fluid in a restricted way. Then also when you're then in D, you basically assess the GCS, and then check glucose, and then you can look for focal neurological signs and the pupils. And we saw that in the other patient, he had the meiosis, which is a small pupils, and they were fixed. And that actually happens in neurotoxic snake bites. And then exposure, look through, and you can get things like blisters, compartment syndrome. Look through that entire limb. And some people even advise when you've just started, you can mark where the swelling has ended, so that you know later on whether it is progressing or not progressing. And then that is the primary survey. So you do your primary survey and fix whatever problem you find. Then you can do some investigations, and these are some of the investigations. You do your CBC, electrolytes, renal function tests, liver function tests, urinal cysts. You can also try to look for myoglobin, and then you do kinase. And then there's this important test. Yes,
Dr.
please.
Joseph. Yes, we are requesting you wrap up in 10 minutes. In 5.
It's okay.
Yes.
It's okay. Yeah. There's this important test, the 20-minute whole blood clotting test, where you put blood 2 ml in a bottle, and then you wait after 20 minutes. You try to pour. If it pours all of it, then it is positive. You have some kind of coagulopathy. If it doesn't, then it's negative. So it helps you know whether you have a coagulation problem or not. And you can also monitor your heart. So then the goal really is to prevent a systemic envenomation. And I've already talked about this immobilization, and other things you can give is tetanus and then antibiotics, especially when there is evidence of infection or necrosis of tissue. Now, I want to go to antivenom, which is really an area of interest. So they are not, we say that not all snakes are venomous. So before you give antivenom, there should be something that points towards envenomation. And these are some of the features, swelling, blisters, necrosis, hypotension, hemorrhage, maybe a laboratory evidence like the 20-minute or coagulation test, neuroparalysis, arrhythmias, myoglobinuria. So antivenoms, there are different antivenoms. They can be polyvalent, they can be monovalent. And poly means for many species, and then mono is just one species. So these formulations are specific. So what I would say, it is very, very important for you to check the manual of an antivenom. And usually they categorize whether it's mild, moderate, or severe exposure. Mild is just some local swelling, and then moderate, you have blisters and some systemic effects. Then severe, you really have a lot of systemic effects. And when you're giving antivenom, so we can give it in two ways. You can give it in normal saline, you dilute it and give it slowly over 2 hours, or you can give it IV push. You can give it IV push over a certain stipulated time. So one thing you should know about antivenom, most people actually react to antivenoms, and you must be ready with your anaphylaxis resuscitation tray. And the signs of anaphylaxis, change in breathing at carrier, you just get a serious skin rash, blood pressures change. So some people can actually give antivenom with adrenaline. In the beginning, they don't wait for anaphylaxis to occur. Whereas some people can give the antivenom, then if someone reacts, they will give what? The antivenom. So someone talked about repeated dosing. Yes, so depending on the clinical, the response of the symptoms to the antivenom, you can always keep repeating the antivenom. And the markers will be coagulation tests are normal, paralysis has reversed. The duration actually depends. For paralysis, you can actually keep repeating after every 30 minutes. Some people can say 1 hour. There's variation in literature on how long you repeat. So other things, you can debride these wounds, and then the other thing, if there's severe bleeding, you may need the blood products as seen. And when there's compartment syndrome, you may need to do fasciotomy. But please, before you do a fasciotomy, your coagulation profile must have improved. In some cases, you need dialysis if some people have acute renal injury. There is a note there. There's no role of steroids in management of snake bites, but there's a role of steroids in management of anaphylaxis, the reaction to snake bites. And these are the complications. I divided them into local complications and then systemic complications. And basically, local, you've seen there pain, swelling, necrosis, gangrene, infections. Systemic, you have things like AKI. This basically affects different organs, the heart, the kidney, the central nervous system. You can get sepsis, bleeding. So document the type of envenomation, describe the snake, estimate the time of the bite, describe anti-venom given, any allergic reaction. And these patients, I would encourage, even if they have improved, observe them for at least 24 hours. Some of them might end up in ICU. Take home message, snake bites are common. Before you administer, look for signs. Prevention of snake bites, basically, wear shoes, avoid areas where snake bites are common, clear your surrounding, and document snake bites include, we must know the common species, and we must know places where there are antivenom, and if possible, the hospitals should get antivenoms. And then the other thing, the cost of antivenoms is really expensive. I was looking at the cost. The minimum is around 800,000. That's the Indian, but the others, like the ones from South Africa and other countries, they are very expensive. It's in over $1 million shillings. Thank you very much. That's the end of my presentation.
Thank you, Dr. Joseph. So as part of the team that managed the patient with snoke envenomation, let's have Dr. Oriba Dan to give his comments.
Thank you very much, team. Dr. Joseph, for the wonderful presentation, and the team from Lacor. First of all, I want to talk about the organophosphate. One, We need to know that in the organophosphate poisoning, we are now having a lot of challenges with the mixed poisoning in the organophosphate and insecticides that we have at the moment. So clinicians have to open up their mind, because you're not only dealing with organophosphate. In the other case that Dr. Makai presented, this is typical
Doctor,
of
we have not
carbon.
yet done that case.
Oh, okay, you have not. Okay, so we need to look at that as well. And on the snake bites, I'm sorry I missed that because I've been for another session. On the snake bite, we have managed so many patients with snake bites, and the geography of location is mostly from Amuro, Noya district, Kitgum, Pader, and they come when they are very sick, especially neurotoxic snake envenomation is the most common. And it's also a mixed kind of presentation. You don't have only typical features of neurotoxicity. If someone has been following my videos on Twitter, you will see that there is typical features of multi-system organ dysfunctions in these patients. They present with the kidney injury because of the muscle twitching which is there. So they get rhabdomyolysis associated AKI. So in the rhabdomyolysis associated AKI, that is where, as a clinician, you are supposed to give, fluid resuscitation plus Lasix to make sure that you increase removal. And then connect these patients on an ECG. There is no patient that has had a neurotoxic snake envenomation has come to Lacor, and we have not intubated that patient. First and foremost, they come when they have a lot of secretions. You have to secure their airway, place them on mechanical ventilation, and you have to use, the ADSNet criteria of ventilation so that you protect their lungs. And at the same time, their temperatures are extremely very high. And we have seen patients whose temperature is 43 degrees Celsius. And even if you give all the paracetamol, expose them and put them in ice, it doesn't go down. So antivenom still remains very core in the treatment of these patients. And as a country, we have to employ wildlife organization, wildlife authority, so that they can extract snake venoms from these people, from these snakes that they are keeping and the rest of it. And we start making our antivenoms as a country. We don't have to depend on other countries to make this antivenom, because the science is not difficult. It is something which can be done. Secondly, the price of antivenom at Lacor is at 400,000. And we have run out of that antivenom at the moment. I remember we had 3 snake bites at a go last week. One of the patients unfortunately passed on because of multiple comorbidities. 2 of them were discharged well. I'll describe this case of this young man who was 26 years old, came with neurotoxic snake envenomation, stage 2 acute kidney injury with very bad hyperkalemia. So he was intubated. The temperature was 42, 43. We had to buy ice from Sinabel. We bought ice from the nearby places, and we just dipped him in ice, mechanically intubated him, and we placed him on 1 hourly muscle relaxation. And again, the reason why I'm sharing this, because it's very important for clinicians to know that once your antivenom is delaying, you're having ongoing muscle twisting, your temperature is going to mediate all the organ failures that will come in. He had very bad arrhythmias because of the temperatures that was there. And we dipped him in ice, he came down, and we put him on muscle relaxation. I mean, complete muscle relaxation with whatever neuromuscular blockage which is there. And you make sure that you set the machine with a very good FiO2 to make sure that they are breathing very well on the machine, and you have relaxed them. Relaxation books have put that, you have to relax this patient for 72 hours, no, for 24 to 48 hours. But in a patient with snake bite, and you have done inadequate antivenoms, okay? Antivenom is inadequate. Maybe you have given 1 or 2 doses. You have to increase their muscular relaxation on the vein, because when you relax their muscles, they are not going to have the generation of heat. the temperatures, which is, by the way, hypothermia in that case, from the muscle twisting, and it's going to kill them. Meanwhile, you will do your CKMB, you will do your cardiac markers, and most patients with neurotoxic snake envenomation, guys, they get acute liver injury. And so you also have to make sure that any drugs which works on the liver, you balance up. Nephrotoxic drug has to be limited. Role of antibiotics would be mostly for ventilation-associated pneumonia. But if it is a local infection, I mean, your amoxiclav is going to work with very good irrigation of the area which is there. Again, going back on the other types of snakes which we have been seeing, the black mamba. The black mamba likes causing you local reaction, very big swelling. When you're managing these patients, elevate their legs up and avoid them from over-utilizing that legs, okay? These patients ideally should be monitored in ICU because any now and then they are going to experience cardiovascular collapse. They are going to get probably respiratory and cardiovascular arrest. So when you are reviewing them every morning, you have to assess the adequacy of breathing. You have to assess their swallowing reflexes, and you have to assess so many other things which is related to compartment syndromes because of the snake bite. But otherwise, I think the team presented very well. And Dr. Makai, I think you will hint on your presentation, but my only issue is that probably we need a broader range and more teaching so that people can remember all the toxidromes and their antidotes. Otherwise, giving just atropine for a patient who has organophosphate poisoning may not be enough. We may have to do more than that. And most of these patients, they benefit with early intubation. Thank you very much, team. I think it has been an honor having me here.
Thank you, Dr. Oriba Dan. Let's have the organophosphate patient case presentation and reactions from Dr. Makai Emmanuel.
Yes, good afternoon to you all. Dr. Makai Emmanuel, a medical officer at Lacor Hospital, currently with surgery department, and I'll be going through the case on organophosphate poisoning. So briefly, our case, we had RJ, a 22-year-old male, who presented following ingestion of a pesticide. This was after following a misunderstanding with his mother. He came in 4 hours after the ingestion with symptoms of excessive salivation, profuse sweating, lacrimation, and vomiting. However, there was no report of fecal urine incontinence. He also had reduced levels of consciousness, confusion, and he was quite restless. No convulsions reported. Briefly, his family social history as an occasional alcoholic, non-smoker, a student, and he's a single young man. On general exam, he was sick-looking or febrile, and his body was had the smell of pesticide coming off it. In our primary survey, as we assessed the airway, we noted he had excessive oral secretions. However, the patient was still able to mumble a few words. Our intervention at this point was to clear these secretions, so we suctioned them out. Moving on to breathing, our patient was dyspneic and tachypneic at 28 breath cycles per minute. He had vesicular breath sounds with equal air entry bilaterally. However, he had diffuse transmitted sounds in all lung fields. He was saturating at 70% on room air, so we switched him up to oxygen therapy by nasal prongs, and his saturation improved up to 88%. However, that is not adequate. We again switched him up further to a non-rebreather mask, and he was saturating at 98%. With this risk of impending respiratory failure, our plan at the point was to transfer him to ICU for better monitoring and management. So moving on to the circulation, our patient here, assessment, he was not pale, had no features of, could move to the next slide kindly. Was not pale, had no features of external hemorrhage. He was mildly dehydrated. His blood pressure of 180 was shown. Pulse rate of 98. Heart sounds 1 and 2 are heard without any added sounds. So at this point, we asked the urine catheter to monitor the urine output. and also to continue to give some fluid. The patient had mild dehydration. In a disability, our patient was restless and confused. He had a GCS of 13 out of 15 with an eye opening 4, motor 5, and verbal response 4. He had his pupils were pinpoint. However, he had normal muscle tone and reflexes, and no other abnormal movements were noted. So at this point, from the history at that time, our plan was to initiate IV atropine, said at 2 milligrams, and we're reassessing every 5 minutes and doubling the dose until with the goal of achieving atropinization. We also did a gastric lavage as a patient had come in 4 hours following ingestion. I believe our expert will give us some more insight on that. And by the time the patient left our emergency unit, he had received 32 milligrams of atropine. That was 1 hour. He spent 1 hour at the casualty, our emergency unit, prior to being transferred to ICU. So moving on to our exposure, our patient was, his clothes were drenched in sweat, and he also had, like I said earlier, was reeking of pesticide. He had no visible external injuries, and his abdominal exam was unremarkable. So our plan here was to remove the clothes, to try to sort of decontaminate the patient, remove the clothes, and also cover the patient to maintain normothermia. Our investigations, which were done, we had a CBC done and also electrolytes. Notably, he had a raised HB of 20.9 and a hyperkalemia of 6.15. However, notably, I'll come back to these investigations. I'll comment on them later on at the end. Now, sample history. Signs and symptoms were, as we mentioned, he had vomiting, hypersalivation, lacrimation, sweating, and restlessness and confusion. There was no allergies reported. Patient wasn't on any medications prior to the ingestion of the reported poison. First medical history was unremarkable, and his last meal also wasn't known. In the events, like I said earlier, he drank the poison. He took poison which was reportedly used to hunt bats, following a misunderstanding with his mother. However, the quantity he took was not known, and also the bottle was not available to us, so we can't really ascertain what contents were in the bottle. And our impression following our assessment was intentional self-harm with organophosphate poison. And our overall plan, in addition to this, was quickly to take the patient to ICU for close monitoring, and then to continue with our management from there. So our problem list was this, as shown here: reduced consciousness, the ongoing toxicity, the cholinergic tox syndrome, and then respiratory depression, as evidenced by his saturation levels. At this point, we're also ruling out carbamide toxicity, which may have a similar presentation to organophosphate. So in our follow-up for this patient, the patient reached ICU, and on our assessment, 2 hours following admission, the patient's condition was deteriorating. He was unconscious, had excessive oral secretions, and also lacrimation, tearing from his eyes, with worsening difficulty in breathing. General exam was as shown there, very quite sick looking. Blood pressure had reduced to 100/65. Pulse was 104. He still had equal air entry with a diffuse chest, a wet chest with diffuse transmitted sounds, and was now saturating at 88 to 90% on the non-rebreather mask. In the CNS, he was unconscious. GCS had dropped to 10 out of 15 from 13. Pupils pinpoint and fixed. And our plan at this point was quickly to intubate the patient, and also to continue IV atropine boluses until we achieved atropinization. Moving on, the patient received an initial, while in ICU, patient received another 16 milligram bolus of atropine. and then was placed on an atropine infusion at 32 milligrams, atropine infusion of 32 milligrams to run over 6 hours. Again, I'll comment on this later on in the presentation. So intubation was done, and notably, he had a lot of secretions, and these secretions were also mildly blood-stained. It was saturating at 85%. This was following the intubation. Actually, at this point, the 6 hour point when he had already been intubated, and he was starting to deteriorate on even mechanical ventilation. He was saturating at 85%. His BPs and heart rate kept dropping. Despite intervention with adrenaline, the patient was still deteriorating, and unfortunately, the patient passed on 10 hours following admission. Now, these investigations here, unfortunately, came after the patient had passed on. There was a bit of a delay in the investigations as the patient came in at night around 4 a.m. And by the time our lab was fully up and running, I think that was one challenge we had. There was a bit of a delay in the results, and hence we didn't really manage the hyperkalemia, which would have exacerbated his condition. Moving on, the few challenges we faced in the management of this patient are there was we're not really sure on which toxin he had ingested, and we saw our working diagnosis was organophosphate poisoning, and we're giving our atropine, but the patient outcome was not really improving. So we were thinking could have been another toxin involved in this patient's pathophysiology. Secondly, we're running out of atropine because we exhausted that on casualty, that in the ICU was exhausted, that in theater was also used. So there's a shortage of atropine, then lack of pralidoxime, which could also be very beneficial for this patient. And then the delay in lab results, which could have made us miss the hyperkalemia, which could have actually been the cause of death of this patient. So briefly, that is our presentation on organophosphate poisoning. Back to you, moderator.
Thank you, Dr. Emmanuel. The questions that we have received so far, someone was asking why was gastric lavage done after 4 hours? Maybe you can respond to that one as we continue receiving more questions from our participants.
So yes, gastric lavage was done as we thought it. Okay, the protocols say a number of things. Some people will say if the poison is ingested within 1 hour, UCG says even up to 6 hours following ingestion, you may do gastric lavage. And since at that time, initially at casualty, the patient wasn't so badly off, there was still just a big risk of aspiration. However, the ongoing toxicity would also be a very big risk. So we opted to do the gastric lavage, try to reduce what could still be there. That's the reason we really did it. We'll have maybe guidance from our expert on that point. Thank you.
Thank you, Doctor. As we continue receiving more questions about the case presentation, let's have Dr. Amanda to run the session for the organophosphate poisoning assessment, emergency management, and complications. They're there.
Okay, thank you, everyone. Thank you for the case presentation. I was just gonna talk briefly and try and highlight some of the what I thought were sort of key parts of organophosphate poisoning to consider, especially in this patient. So we're just going to talk a little bit about, what we're looking for in our assessment, and then in our emergency management, and any potential complications that we have to look out for. So unfortunately, organophosphates is a very broad sort of category. That's why a lot of times it's really good if somebody can bring the actual product that was ingested, because what's actually in it, even as Dr. Oribe was saying, can be very different product to product. And somebody will tell you the name of something and you look it up and it's not actually what the patient took because they took something else in that same brand variety. So you can get very different effects that way. But in general, organophosphate poisonings have to do with the fact that organophosphates affect acetylcholinesterase. So as the picture, the cartoon is showing, acetylcholinesterase is what activates receptors in our nerves and cause all of the things, all of the symptoms that we're seeing, the sweating and the salivation and diarrhea, vomiting, all of those things. And the organophosphate, normally those compounds are broken down by an enzyme in your body. And the organophosphates come in and they stop the breakdown of that. So now, because those are not being broken down, now there's too much of it. Now there's overstimulation and excess production. And that's where all the signs and symptoms that we see come from. So when it is overstimulating and overactivating on the muscarinic side, that's where we get our sludge. So that's our, or some people even call it dumbbells, the salivation, the respiratory symptoms, the GI symptoms, all of those things come through because of that overstimulation. And then on the other side is where the nicotinic receptors get overstimulated. That's when we get into some of the difficulties with respiration, because you can get paralysis of muscles and things like that. You can get even some increased heart rate from overstimulation. So all of these things together is what we see, because those receptors now are getting way too much work than they would normally get. So an important point when we're coming to manage a patient is we have to decontaminate. So if a patient comes in and they smell a pesticide, if they vomited on themselves, we have to get that away from them, and we have to get it away from ourselves. So first things first is you have to put on your PPE and protect yourself, and then you have to remove all of this from the patient. Organophosphates can be absorbed through the skin. And so it's important to wash them off and to get as much as you can away from them, because you can get continued absorption and continued symptoms if you don't decontaminate the patient. So this is in, I guess, contrast to what we normally think. Normally we think A, B, C, D, E's first, but in this case it's protection first. Protect yourself, then decontaminate the patient, then you can assess the ABCDs and go on from there and intervene, as happened in this case with airway issues and stuff like that. The big things that we're looking for are what we call our killer bees. So the things that are most significant that are going to harm the patient are the bradycardia, the bronchoria, which is excess and pulmonary edema, and then bronchospasm as well. So that's why they get into respiratory distress and respiratory failure, like in the patient that we had. So those are the things that patients, who don't quite have those symptoms yet, maybe you think they took a mild ingestion or they haven't quite gotten to that state yet, those are the things that you're monitoring for. Obviously, if they come in with them, then they're a severe case. But if they haven't quite hit that mark yet, then those are the things that you want to look for. So in order to deal with the overstimulation of these particular areas of the body, like I said, you get the muscarinic and then nicotinic effects. Atropine is what we use to treat those muscarinic effects. So essentially, because you're getting this overstimulation and this overproduction, the atropine comes in to sort of block that so that you can get the normal physiologic pathway to that would offset that normally. And that's why it takes such high doses of the atropine, is because you have this overproduction, you have way too much than is physiologically normal. And so then you have to use large amounts of atropine to overcome all of that extra. And then the actual, what I think of as sort of like the antidote to organophosphate poisonings is actually the pralidoxamine. So that helps to reactivate these enzymes that would normally break down all that extra acetylcholinesterase, acetylcholine that you have floating around. So it is going to stop the organophosphate so that now you can actually break down this enzyme. So now you can get back down to the levels that you're supposed to be at. So it's the actual like antidote to the organophosphate. So it's two-pronged. So if you're only doing the atropine, you may be missing that other part of it. Atropine is just treating the symptoms. As I mentioned before, what we are looking for is sort of those killer bee things. So we're looking for, you know, the bradycardia, the respiratory failure that's going to happen at some point in time from all this extra acetylcholine that's floating around. And the risk of that is obviously if you are having all these extra symptoms, you know, respiratory symptoms with vomiting and respiratory distress, aspiration, respiratory failure are very high on the list. There are these cases where, you know, people seem to be okay, and then hours, sometimes even a day later, they start developing other symptoms. And it has to do with the fact that there's that, I mentioned there are those nicotinic receptors that get affected. And sometimes it's a delayed process in those effects actually wearing off. And so after even sometimes their initial like hypersalivation and all that stuff gets better, they still may have some of that muscle weakness from those other receptors, and then they get into respiratory distress hours later. Not with like the bronchoria and stuff like that, but more with like muscle paralysis type situation. So that's why even if a patient comes in looking okay, if it hasn't been long enough, like, you know, it's only been a couple of hours or something like that, it's good to still watch those patients to see, you know, are they gonna get worse? And so in general, I think a good approach to patients in general with poisoning is always consider, you know, your ABCDs. If the patient comes in still with that, you know, potential poison on them, then first thing you need to protect yourself and decontaminate the patient as much as possible. Gastric lavage and activated charcoal, a lot of the evidence says 1 hour, maybe 2 hours. It's indicated to give those things. It does depend a little bit on the compounds that are available. Actually, organophosphates, activated charcoal doesn't work well in those. And gastric lavage, like I said, after like a couple of hours, maybe 2 hours, you can still get some effects. But as they said in this particular case, the patient was having ongoing symptoms. So you may consider, you know, your risk of aspiration versus doing a gastric lavage just to see if you can decontaminate, do GI decontamination in that sense to see if you can get improvement in their symptoms. So it's kind of a case-by-case basis, but in general, I wouldn't think of doing it after like 2 hours of ingestion. And then when you're assessing the patient with a potential poison, there aren't that many antidotes out there actually, and there are a few that are on this slide, but having like a reference somewhere for like the most common sort of antidotes that are available, but most of the things that people get poisoned with don't have an antidote to them. And so a lot of it is just supportive care and knowing that the expected sort of time to observe for side effects of those drugs or things that they took. The other thing is that even the direct effect of the toxin, there can be other things that can happen along the way as their body is trying to, you know, help to save them from this toxicity. So even in the patient that we saw, you know, some of the abnormalities in their labs have to do with like their body also, you know, dealing with the poison and the toxin. So it's not just the toxin itself and treating that and making sure, you know, that you're giving the antidote if there is one, but also recognizing that other things are going to happen. Even like in the snake bite, you can see where they developed, you know, renal failure, probably from their rhabdomyolysis. So you have to anticipate, you know, that that's going to be happening as well. And assessing them for potential co-ingestion, because if, you know, you can get one thing in, then you can get another thing in, and people may not tell you about that. So that's why sometimes labs and ECGs and things like that can be helpful to look for those co-ingestions. And especially if your patient's not responding to your standard therapy, then you have to think about that. And then in all sort of poison patients, I would say, at least, even if they seem like they're okay, probably at least 24 hours of observation to make sure that they don't get any sort of delayed effects of what they may have taken. If you know the agent and you can be certain that, you know, it's going to have worn off in 6 hours and now they're 8 hours and they're fine, then maybe you could consider, you know, not monitoring them as long. But in general, even the patients that look okay, I would keep an eye on them and have very close monitoring of their vitals up to 24 hours after their ingestion, just to make sure that they would be safe. So that's kind of all that I had. I will turn it back to the moderator.
Thank you, Dr. Amanda. Since we don't have so many questions, I think I can first call on the Commissioner, Emergency Medical Services, to give some remarks. Dr. J. Nambohe, we request to hear from you.
Yes, good afternoon. Nice to be here. Thank you for the discussion on this very important topic on poisoning and also the snake bites. Thank you, the moderators and the facilitators. Today, you are discussing a very important and frequent emergency, and I want to appreciate all the field teams who have attended. I've seen it's a very high level of attendance. I want to appreciate that, and also thank SEED Global Health for always being available to support these initiatives. The Permanent Secretary was supposed to attend this, but she got occupied. I think she will attend the next one. But just to say that she appreciates the participation of the field teams in these eco sessions. We remain grateful. I remain Dr. J.B. Wanyai Nambohe, Commissioner, Emergency Medical Services. Thank you so much. Good.
Thank you so much, Doctor. When I look through the questions, most of the questions have been answered online, but someone was asking the maximum dose of IV atropine in 24 hours in case there is no atropinization. Maybe Dr. Amanda can help us answer that.
So your target is atropinization. So the maximum dose is whenever you achieve that. So atropinization, you know you've achieved it, especially when those like killer bees are improved. So if their bronchoria, their respiratory distress, their heart rate, their bradycardia is improving, then you know they're properly atrophonized. If you haven't hit that yet, then you're still going to continue to give them boluses of atropine. I don't think you can just stop and start giving an infusion until you reach that particular level.
Thank you so much, Doctor.
Also because the infusion is based upon how much you gave to achieve that. So if you haven't achieved that yet, you don't know how much to give in the infusion. Sorry.
Thank you so much for attending this session. We've been able to achieve our goals, I think most of them, and the questions that have been not answered, the answers will be submitted to the experts and will be sent to your emails directly. I think we can have the session discussion. In case of any question that can be answered there, and then you can be sending. In case there is no any burning question, then we can have the closing remarks and the post-test questions. Okay, let's be having the discussion on. Someone had a hand up, I think. So Castro, you can raise your question.
Yes, thank you very much. The presentations were quite amazing. I literally have one question. On the first case, we were wondering, you know, there are myths that they used to say that you could actually, if, for example, if you get a snake bite, maybe by a swampy snake, a snake within a swamp, and probably run to drink some water, it is said that the snake would die if you drank the water first, and the reverse would be true if the snake drank water first. So I don't know how far true that is, because seemingly it has been encountered. My other question, however, would probably go to Dr. Oriba if he was still online. A concern on organophosphate management. I am quite touched by the fact that these days patients actually present with mixed poisoning vis-a-vis the classical presentation that we probably thought about. However, we have been thinking around the clock about the maintenance of the maintenance dose for atropine, probably to continue over the next 24 hours, as opposed to having achieved the full atropinization. If we could probably give some light on that, so that we could see how we could probably improve on our management of organophosphate poisoning. Thank you.
Let's have Dr. Emuron to answer that question, as Dr. Riba will be raising his question, then we will answer the question that has been sent to him. Thank you.
Thank you very much for the question. I've also had a similar thing, that if you go into a swamp and then a snake bites you, something like you will die when you come out of the water, that you've got to be given maybe some treatment when you're still in the water. So from the literature that I went through, I did not come across anything related to that. However, what I noted is that some of those snakes in the sea, some of their bites are dry. That's what I saw.
Thank you so much, Doctor. Dr. Oriba, you had raised your hand, but you can even answer the question that has been posed to you.
Okay, thank you very much, team. Doctor, that was an excellent presentation. However, I just wanted to add on the organophosphate, because at the moment we are losing really patients. I can say that every day in Lacor we have, in a week, we have a minimum of 5 patients of organophosphate that we ventilate in our ICU. Some of them would go back to the ward. So they're coming up with the late symptoms, sometimes together with a mixture of toxidromes. Needed you to put a little bit of emphasis on the other toxidromes plus their antidotes that you projected. That slide was really very important, because you tend that we tend to give very high doses of atropine, and we forget that there are other toxidromes that come. Interestingly, I'm not seeing psychiatric management coming out clearly, but I had one Muzee that we ventilated in ICU. We discharged him very well. We talked to him afterwards. He went back a few days ago. He took large doses of organophosphate and came back and died. So psychiatric assessment of these patients is very important prior to discharge, and then follow up of them. Going back to the question, maintenance dose of organophosphate has been, maintenance dose of atropinization has been reported in so many studies, and it varies about 10 to 20%. But if you have achieved atropinization with probably 15 milligrams of atropine, then you get 20% of that atropine, or 10% of that atropine that you have used for maintenance for maintenance. Then you do that 1 hourly. So there are 24 hours, 24 hours in a day. So if you find that you needed 1 milligram per hour, then that is what you set. You will set 24 milligrams in the infusion pump, and you set it to run for 24 hours. That has to be done for over 24 to 48 hours, because we know that patients with organophosphate can still continuously release the organophosphate because it is stored in their muscles and other fat tissues. So to help them in the maintenance phase. But again, going back, on the issues of organophosphate, again, presenting very late, I wanted the doctor to clarify. I always have mixed feelings in terms of, lavaging these patients. Do you have a role of lavage, really? I don't encourage my people to lavage patients unless I have airway protection, because most patients who have been lavaged without airway protection, they have not made it really very well. They end up, taking up the organophosphate. You are increasing the absorption of these toxidromes, because some of them, since we are thinking that it is mixed, we are thinking that probably when it is now mixed organophosphate with other toxidromes, then probably doing lavage in this patient would aid the rapid absorption. But I would only encourage lavage when I have airway protection. I have intubated you, or you are really, really conscious. I am taking you to ICU, and I know that I will have adequate lavage for this patient. So without that, I don't encourage lavaging them. There are other aspects that we don't put. That's the monitoring of these patients once they're on, invasive ventilation. We have to monitor organophosphate patients. They are presenting with arrhythmias. You will see someone having very many frequent premature ventricular contractions on the machine, which is not good. Some of them go into atrial fibrillations. And we have also seen that they are getting a lot of electrolyte imbalances. So trending these electrolytes with the clinical response each and every day that you see them, I think would increase their uptake in thinking. And then lastly, doctor, I think we shall be very much happy to at least do some study on organophosphate with your team to make sure that we find out why people in northern Uganda are taking organophosphate so much. That would be very important. Thank you very much, and may God bless you for this session.
Thank you so much, Doctor. Let's have Niwamanya Peace raising the hand to raise her question.
Yes, thank you, Tim. My concern was about the psychiatric assessment of this patient of organophosphate poisoning, because we saw it was a serious self-harm. I think going just back into from the start after the patient had improved, I think it was very necessary to make history and find out the major cause of this cause of self-harm. Otherwise, if we didn't do that, then we could help the patient and probably the self-harm would come back.
Come on, we got this.
Well done. Thank you so much, Praise. Alifonsi.
Thank you, Tim.
Yes.
Yeah, thank you, Tim, for this excellent presentation about this organophosphate poisoning. Yeah, so my question goes to the doctor. I would want the doctor to explain to us when can we start aggressive management to these patients who come show up to the emergency department and say, I took something which is organophosphate poisoning. Because sometimes someone accidentally gets something to their tongue and they realize this is something I shouldn't have taken. So such patients, do I need to like go on gastric lavage and all other managements? So I really, doctor, would wish like you will echo on when can we start this aggressive management of these patients. My other concern has been attended to. That was about disposition of these patients. When someone comes, you treat because of like the guilt going back to the village, they again take the poison. Thank you so much.
Thank you. Let's have Dr. Amanda to answer that.
Yes, thank you for your question. I would say some of it depends on the amount you think they might have taken, if actually doing like the gastric lavage would be helpful. If it's somebody who, I mean, most people would recognize right away, like, oh, I'm not supposed to drink that, and they wouldn't have ingested that much. And so I don't think that gastric lavage would necessarily be helpful and could be more harmful in trying to do that in that particular patient. If for some unforeseen reason, somebody drank like an entire, bottle, like 300 milliliters or something, then that would probably be someone that, would potentially benefit from gastric lavage. And they would need airway protection, I would think. As the other doctor, Dr. Oriba said, so oftentimes when we're trying to do that, patients they don't tolerate it well, they vomit and they aspirate, and that puts them in a way worse condition than if we had just let them absorb the organophosphate. So that would be my thought about this situation. Like, most people unintentionally don't ingest that much, but if they have ingested a lot, I would also say it's probably not unintentional, and then you have to be more aggressive in that sense. But yeah, I also think that you could monitor if they come in right after the ingestion and see if they're starting to develop those other symptoms. That would also kind of give you a clue of how much they may have actually ingested. But most of these substances, I mean, they don't taste good, so people aren't going to drink a lot of them accidentally.
Thank you so much, Doctor.
Hello.
Oh, we are welcoming more questions.
So, Dr. Amanda, I have something to add on. This is Dr. Emuron.
Yes.
Yes. Yes, I thank you very much, Dr. Oriba. Thank you very much, Dr. Amanda. So my thoughts on this, the other key thing we really need to pay attention is going back to the containers or the kind of like the drugs which these patients take. Really getting the container, and you go and look out the data sheet, because I have seen patients who take milbitras, which is actually resembles organophosphate, but it does not have actually organophosphate. So getting to know the actual container and what ingredients are there, and then doing more research about that might be helpful. And then the other thing is some patients actually sometimes they do what's called co-ingestion. They can take multiple drugs at the same time. And that again goes to what Dr. Oriba was saying. They can present with different toxicants. So such patients can present with those different toxicants. So history really plays a key role. I've also seen patients who just want to seek attention. Recently, I saw a female who came that their daughter that she had taken poison, but in actual sense, when we started wanted to put an NG tube, then she got up and and she moved away. So again, it goes back to the history and assessing, really getting the circumstances. Yes, I would agree with Dr. Amanda. Really depends on how much someone took, but sometimes it's very difficult to pick out that. I would, in that case, I would just admit that person, observe them for some time, and be ready for any of the options available. Thank you.
Thank you so much, Doctor. Thank you for attending today's session. So I think I can hand you over to Dr. Thomas to give us the closing remarks and the post-test questions. The post-test questions, I think they are on. We can be answering. So as we are doing our post-test, let's have our closing remarks from the panelists we've been having today. We shall start with Dr. Fiddy to give us his comments about the session.
Okay, thank you very much, moderator. I'm really glad the attendance was so good, and we really had a lot of key learning points, which we have really learned a lot in regards to management of snake bites and then organophosphate poison. This will, I believe, it's going to improve on the management of our patients. Thank you.
Okay, thank you, Doctor. Let's have Dr. Makai.
Thank you so much. Thank you for the presentation, for the organization of the presentation. There's been a lot to learn. We thank the experts for their added points. And we hope that now we can all better manage our patients with both organophosphate and snake envenomation. Thank you.
Thank you so much, Doctor. Let's have Dr. Joseph. And lastly, Dr. Amanda.
Thank you very much, Echo. Thank you very much for making me be part of the session. And thank you very much to our online audience. You've been really engaging, and I think people have a lot from this. Now that we've gotten the knowledge, we go and serve people in a better way. Thank you once again.
Thank you, Doctor. Our participants, as we are getting the closing remarks, we can be answering the post-test, it is on. Let's have Dr. Amanda.
So thank you for all of the great questions that everyone asked and all of the participants that we had. I just want to end with making sure, the key points that we emphasize throughout this is that making sure that when it comes to poison patients, that we're safe and we decontaminate the patient so we don't have more patients with similar symptoms, that we assess the ABCDs, E's, and manage them appropriately, looking at the toxidromes and just considering that a lot of these chemicals are mixed, and so we may get mixed toxidromes. And so if there is an antidote, we may have to consider different ones. Even with envenomations, they're not going to have just one toxic effect. They're not just neurotoxic and hemotoxic. They can be mixtures of both. And if possible, if we can get the snake or a picture of the snake or the chemical that somebody may have ingested or poisoned, then that's helpful as well in our diagnosis and treatment. And I think that having all of that together, we're going to do much better taking care of these patients moving forward.
Thank you so much, Doctor. So we are coming to the end of our session. To our participants, thank you so much for attending. So we recommend you to always attend these sessions. We hope to meet next time. Thank you. Anyone with a comment can still be can raise the hand or send them.
How do we get the CPD link?
For the CPD link. Link, I think, is going to be sent. You'll be seeing it. So people can be answering their post test. We are waiting. Ongodi Emmanuel.
Yes, good evening, our presenters. Thank you so much for the presentation. It's really been a productive one. Though we are requesting if there's a possibility that these slides could be given to us so that we could do the follow-up. Thank you.
So the slides are going to be uploaded on the website. We have a website. We are working on uploading all the slides, and the video will be on our YouTube channel. You just go to Google, put EMS Echo Uganda, you'll be able to access our website. And for the YouTube, just go to open your YouTube, type in EMS Echo Uganda. You're going to see the YouTube channel where the video is going to go in the next 1 hour. As soon as the session is done, we shall upload the video. So as we are ending, we are requesting that you give us a response to the general session evaluation. Tell us how you found the session, and then we shall share the results of the polls in a few minutes. So the faster we answer, the faster we're able to look at the answers to the polls. Also, if anyone has burning comments as we are going to end, please you raise your hand and raise your comment. We are going to have our next session in 2 weeks, and we are going to be covering DVT. So come and learn from experts who are going to discuss DVT. those that would like to take screenshots with us, please put on your cameras as we respond to the calls, and we take the screenshots. Those that are interested, we would encourage everyone to enjoy this moment with us. The screenshots are all going to be uploaded on our page. Let us respond to the general assessment. This one has no right or wrong answer. It's just your feel, how the session was. Are we able to see the correct answers for the questions? I think Dr. Joseph, can you take us through the first two questions briefly, very fast? Dr. Emuron?
Yes, please.
Can you take us through the first two questions? Yes.
Yes, so the first question, the correct answer is C. What is more likely to tell you that this snake is venomous is the fang marks on the wound. Other snakes, they can bite you, you may get a swelling, but a bite wound is fang mark is strongly suggestive. And then the second one, in terms of first aids, it's more to do with limiting the activity. Tell someone to be calm and then try to immobilize that part of the body to prevent the poison from spreading. That is the first aid. Then now you call for help and see how the patient can be transported to the hospital.
Thank you, Dr. Emuron. Dr. Amanda, can you take us through question 3, which says, which of the following would not be a sign of organophosphate poisoning?
So, as I talked about, organophosphates.
We wanted to start doing community activities, but
cause overstimulation and extra production of things. So what would not be is urinary retention. So you'd actually have increased urination, as well as all the other things, increased salivation, you get pinpoint pupils, and you do get a slow heart rate.
Thank you, Dr. Amanda. Question 4 says, a patient presents with altered mental status, increased salivation at a heart rate of 45 beats per minute. What is the most appropriate next step?
So at this point, assessing the airway, so we start with our ABCD, like we would always do. So we would, not jump to medication first. We would start with airway protection first.
Okay, so the answer was A, apply oxygen and assess your airway, because you don't know what the cause is at this stage. The question was general, regardless of this being a topic of organophosphate. The question 5 says all suspected organophosphate poisoning should receive activated charcoal. Is that true or false?
That's false. So it actually doesn't work well on organophosphates, but sometimes we do give it if we think there may be co-ingestions.
Okay, so I hope we got that. Question 6 says, when organophosphate poisoning is suspected, the first steps should be, what would you do first?
Decontamination is the first step. So we want to make sure that we're safe so that we can take care of the patient. So we have to wear our PPE and take everything off the patient, wash the patient off so that there's no contact or skin absorption.
Okay, so we all got that. The answer is decontaminate the patient, because we said organophosphate absorption also takes place from the skin. So As you assess your airway, the patient is taking in a larger dose of the organophosphate. So the correct answer was decontaminate the patient. I think most of us had chosen assess ABCDE. Let's get that correct. The last question, most people got it, and it is admit for observation for at least 24 hours after ingestion. Thank you so much. And we shall be happy to see you in 2 weeks. Please, if you have any questions, feel free to email us on those emails where you received the link, and our contacts are there. Please reach out to us. Thank you and enjoy your weekend.
Thank